Well, good afternoon or morning, depending on where you're tuned in from. We've seen the title. Let's move into the next slide. What I plan to do today is review the reports that are available in your PQRS portal. I'll be how to access them. We'll review the timeline. We particularly wanted to get this presentation in now because the clock is ticking on your ability to file for an informal review. That filing for informal review is due by November 30th. So understanding the report and whether or not you need to file for a review is extraordinarily important. So then we'll get into the meat of things, and I'll just be reviewing a couple of sample reports. I've also pulled up a feedback report which covers the PQRS system. The QRUR report covers the value-based modifier system. And then no presentation would be complete at this time of year without a sneak preview of the 2017 MIPS MACRA. So if we have time, we'll review some of the highlights of that just as a teaser before our webinar in a couple of weeks on the full rule. So step one, if you haven't received it already, this is where you get it from the portal.cms.gov. You need credentials to get in. If you haven't created credentials, you'll need to get started. It can be time consuming to get those credentials. Although one of the worst things is to have your credentials but have lost your security officer, because that is required to grant anyone credentials. We do have a brief survey right now. Charles, would you distribute that, ask people about their access to their reports? Hello?
Yes, I've launched the poll. We wanted to just get feedback from everyone before we dive in if you've access to your 2015 QRUR yet from CMS. So please do take a quick moment here. We'll move right along. So far, about 45% have downloaded their QRUR and reviewed it with their team. All right, and we will close the poll here just at 1 minute in. Thank you everyone for participating.
Great. Now, before I leave this slide, let me point out that when you sign into your portal, go to the indicated link for feedback reports. Your QRUR reports, the various QRUR reports should be available there. The PQRS feedback report should be there. If you do need to file for an informal review, the link just below that, Value Modifier informal review, is there. I'm not certain that you can access the PQRS informal review from there, and I do want to point out that they are different. If you've got an adverse finding in PQRS, that informal review is a separate process than having your value modifier scores reviewed. So here's a schedule of various reports that are available. The feedback report is about PQRS. We expect that will disappear when we go into MIPS MACRA because that will no longer be pertinent. It's typically available at the same time that the QRUR report becomes available sometime in the third quarter of every year. It became available about 3 weeks ago with the QRUR reports, which is your report on value modifier and quality tiering. It's when Medicare finishes all the processing on the quality submissions done by March 31st that these two reports come out. There is a supplemental report that comes out typically in the fourth quarter of the year, and that covers episode cost performance. Now, you're not being judged yet on episodes of care, but that will be a big part of the MIPS MACRA program. Of course, if you've been watching the final rule, cost has been eliminated as an analysis in the first year of the program. We're expecting it to be back in the 2018 measurement year, and episodes of care will be prominent. Episodes mean that even specialties which found themselves exempt or with very light data requirements in the value-based modifier and quality tiering analyses, they'll find many more affable costs of care measures that may be applied to them through those episodes. So what's presented in this episode of care cost performance supplement is all those proposed episodes of care and how you are performing to date on those, so you can start getting prepared. There will only be a limited number of those that are brought live in the first year, and they may change from year to year, some being discontinued, some being added, the kind of evolution we've seen right along with PQRS measures. The mid-year report comes out typically in the second quarter of every year and is designed to give you a progress report on your cost measures. The measures that you'll be graded on in the annual report that comes out in the third quarter, but this one covers the July 1st to June 30th year, the last available set. And just gives you a warning how you're performing, so you can make some adjustments. Although there's hardly enough time to do much, receiving it in the second quarter after your last year has been completed and you're being judged. The new data is being evaluated for judgment for the previous whole year. And then I've heard claims that there's an interim report out there. I've yet to see one, so if you get one, send it to me, if you will. Theoretically, it shows how you're doing in claims performance if you're making a claims submission, and it's year-to-date data. And again, I'm not sure exactly when it comes out. If in fact it comes out, it may be a Bigfoot or Yeti kind of a thing. So let's look at the timeline. It's a relatively busy slide, but it'll show you where you are. We are at that black vertical line here toward the end of October. We finished our submissions by March 31st of the year with various due dates for the various specific mechanisms. We're already past your GPRO self-nomination due date of June 30th. You are heavily into the year collecting your data for the 2016 performance year or reporting year. And again, we'll get around to pulling that final data set together in the first quarter of 2017 to make your final PQRS submission. Now, I say there at the bottom right that PQRS ends March 31st, but it doesn't really. It's really not over until the crying's over. And the crying's over at the end of 2018 when all of the adjustments pay out through the end of 2018. And then 2019 is the first payment year for the quality payment program. And of course, 2017, that whole year is the first performance year or reporting year in the quality payment program, MIPS and MACRA. Now, your 2015 feedback reports in QRUR became available about the 1st of October. And so you should be able to find it in the portal if you look for it now. And that started the clock ticking. You have 60 days after those reports are are out to apply for informal review. So the Medicare is saying that the deadline for requesting informal review is November 30th. And remember that there are two different systems. An adverse finding in the PQRS system demands an informal review through PQRS, and an adverse finding through the value-based modifier system demands an informal review through value-based modifier. We saw in that previous slide that there's a link in the portal to request a value-based modifier informal review, unless you also see a link there to the PQRS informal review that may be submitted solely through the help desk. So you contact the help desk for that. Now, sometime we expect penalty notices to come out, but I wouldn't wait for them to request your informal review. They've been unpredictable at best. They might be much later in the year. They might even be after the informal review request deadline. In fact, if any of you have received one of these, we'd be anxious to know, just so we can let people know that they are coming out. That's just about everything I think we can glean from that slide. So again, just one more time to hammer it in there, two different systems. So if the adverse finding is through PQRS, you have to request a PQRS informal review, and as far as I'm aware, that'll be through the help desk, although it's worth looking on the portal to see if that link for VBM informal review also gives you a link to the PQRS review. And value-based modifier requests also due within 60 days after publication of the QRUR. So let's move into some actual reports, some de-identified reports to start to understanding how to look at these. So let me just, I'm clicking out of the PowerPoint deck. And so when you download these, you have a number of choices. I tend to like the PDF format. It can also be downloaded in a CSV format, which is somewhat useless because nothing's really presented in tabular form. So I think the formatting is more predictable and easier to read in the PDF. So I'm just opening this PDF, and I'll bring it over here. There we go. And it looks something like this. Oh, exactly like this, in fact. So it's headed with the year and the program, the 2015 report. This is based on 2015 data submissions, which were due March 31st, and it has to do with the 2017 payment. So of course it'll be this coming year that will affect your payments. It identifies your practice name. We're calling this really the best healthcare practice, and we de-identified the last 4 digits of the tax ID number, and it again confirms the date range of the data that was considered in this report. Now, in the very first page, in this very upper part, is really what you need to know, and it starts with describing what your performance was on the value modifier. And here in our sample practice, we're seen as average quality, average cost with a neutral adjustment, which most people are considering great news. It's very hard. You have to be in the upper 10th percentile to be in the incentive range. And of course, if you're in the lowest 10th percentile, or if you did not submit accurately, then you could be due for a negative adjustment. And then it goes on to explain, gives you just a little more detail in this statement down below. So just stating it with a little more detail. Now, we're presented with the same data in a graphic sense. So this is called a scatter plot, and it shows this box in the middle. This area is the average. it's the center, it's where quality performance is average, it's where cost performance is average, and if you fall in this box, you get no adjustment one way or the other. In this box, a negative quality adjustment is offset by a good cost adjustment, and again, you're zero. In this box, a high quality adjustment is offset by a high cost negative adjustment, and again, you're zero. So anywhere in this center diagonal, you have no adjustment one way or the other. Then remembering that quality tiering is pass-fail on two parameters. It's pass-fail on quality, it's pass-fail on cost, and your ultimate adjustment on the two factors are the addition of the two. In this case, looks like we're in the plus or minus 4%, so it's 2% each on quality and cost. In this space, we've gained 2% for low cost, but we're average for quality, so we gain 2. We gain 4 in this box. We gain 2 in this box. And then down here, we lose 2 in this box, or lose 4 in this box, lose 2 here, and lose 2 here. So graphically, it puts us right in the right near the center, which is good. No loss, no gain. And then let's drop down again. It puts it the same data in yet another format in this tabular form, and Medicare highlights this 0 to say this practice is not due for any adjustment, positive or negative, and it shows the +2, -2, +4, etc. in the various boxes. Again, the same data that was presented in a slightly different way here and in text up above here. So that is the most important thing. If you've determined that you've gotten a negative adjustment and think it might be an error, then you should, or if you think it's not fair, and that's a reasonable thing to bring up. I've seen some ways that statistically cost is being attributed to practices in ways that you have no control over, and I think it's worth making your feelings known about that. So don't hesitate to file for an informal review. You can't get anywhere if you don't. They're not going to come back and correct their findings. So without your asking. So now let's continue to leaf through the report. Next, it will give us details on the quality and cost analyses. First comes the quality. Now, if you recall, your PQRS report had to have 9 measures in 3 domains. Not exactly had to have. There's some exceptions to that, but in general, a qualifying submission is 9 measures that sort into 3 different domains. Medicare also calculates 3 measures in the background that are in the care coordination domain, and that's also reflected in this report. So the first thing they do is look at the total quality composite score, and in this case, when they brought all the scores together, Medicare judges that our score in this sample practice is 0.29, just a little above average, but not enough above average to earn the incentive. And this yellow box here is the average range, which is the average plus or minus 1 standard deviation. You don't gain the positive incentive unless you're more than 1 standard deviation above average. You don't earn the negative adjustment unless you're more than a standard deviation below the average. So we're again in the safe range here, no gain, no loss. Next area, Medicare details the quality metrics that went into each of these. So, and then it goes domain by domain. Medicare takes takes the measures you've submitted and they've calculated, they group them by domain, they create an average on each of those domains, and then they average the domains together, and what we looked at a moment ago was the average of the domains. So there is some strategy that this implies for choosing your measures, and you can use some higher performing measures to offset some lower performing ones in the same domain, or you can isolate a poor performing measure in one domain so that higher scores in the other domains can offset it. But here, for each measure, we go through the identification of the measure, the number of cases that were eligible, and this comes directly from your report, the performance rate that comes directly from the report that you gave to Medicare or we gave on your behalf, a standardized score. And this standardized score compares your performance rate with the benchmark rate and that standard deviation. So this is the number of standard deviations above average that this represents, that this number represents. Now, because this looks like lower performance, you'd think you might have a negative number here, but the diabetes measure is an inverse. So, and in the standardized score, they adjust for the inverse measures. Now, this one is not included in the domain score. And I'm challenged to understand why that's not included in the domain score. I think it's because it won't be included if the specifications change. And I believe the specifications for this measure changed for the 2015 reporting year. It also will not be reflected if this number is below 20, and obviously that's not the case. The diabetes eye exam, likewise not included in the domain score, and again I think it may be because a minor change in the specifications, so the benchmarks that Medicare developed in the past are not relevant. So we've gone through all these measures that are in the effective clinical care. We've added them up. Mathematically, it's not going to work out exactly because the final score is going to be adjusted for risk, but it will be close. We move on to the next domain, person or caregiver centered experience. We get a slightly just below average number at 0.06. And this again is, in fact, that's all coming from the CAHPS survey in this case. So it's the average of the CAHPS survey scores. And that comes through in that. Then we go on down to, where's next? Community and population health measures. That's the influenza, pneumovax, BMI, depression follow-up, tobacco use, high blood pressure screening. We see the number of cases again, the reported performance in your submission to Medicare, the standardized performance score, which compares that standard deviation away from the benchmark, whether or not it's included, and the average, which is a favorable 0.88. Getting close to that one standard deviation above, but not quite. We move down to the next domain, patient safety domain. There's two measures in that. We see your scores here, which average to 0.53. And then communication coordination. This includes the measures that Medicare calculates in the background, so-called administrative claims measures. And this is about ambulatory care sensitive acute admissions and ambulatory care sensitive chronic disease admissions, plus an all-cause hospital admission rate, the number of eligible cases, performance rates, and again standardized. So you don't have anything to do with submitting the data for this. This is about the experience of care for patients attributed to your practice. If you have no patients attributed, of course, these won't result in any scoring. There are other measures that could sort to this domain, and they would be averaged into this for your final score. Then there's and then we get into the efficiency and cost reduction domain, which are the cost measures. So we've graduated from the quality measures, that's based on your PQRS submission, and the administrative claims measures, and we go to the cost measures. And in this case, our cost is slightly above average, but again, not so much that we fall into the penalty range for being high cost. So well away from that one standard deviation limit. Then there's a lot of explanatory text, which is the same report by report. And then we get into the meat of your performance. So the first is the cost for all attributed beneficiaries. Now, again, this is patients who are attributed to your practice based on where they get if they have more primary care visits with your practice than with any other. This measure, the per capita cost for all attributed beneficiaries, is the average cost per year for taking care of a Medicare patient in your practice. And in this case, at $12,570, it's slightly higher than the $12,326 national average, and the standard deviation being 3,665, well within a standard deviation of that. Now, it looks like I've got a couple of questions. Let me pause to have a look at those. Maria asks, we noticed on our QRUR that the benchmark plus standard deviation above was slightly higher than 100% for certain measures. This did not allow us to obtain a higher than one standard deviation score on those measures in question. Since as a radiology practice, we only had these types of measures to choose from, we were never able to achieve high quality incentive. Were you aware of this, and will this go away in the first year of MIPS with topped-out measures being delayed? Not sure if the benchmark standard deviation calculations will be the same with MIPS. And the answer is no, this doesn't go away. That it will continue to be a problem. There's a lot of measures that are topped out. And topped out really means that the standard deviation brings you, to be a standard deviation above average, you would have to be above 100%, which is not possible. Now, in another way, it does go away. What we have in the PQRS and value-based modifier program is cliffs. That you don't earn the incentive until you get to one standard deviation above average, and you earn it all at that point that you fall off that cliff or climb that cliff, or I don't know. And then on the other end, you don't lose the 2% or 1% until you are one standard deviation below and you fall off that cliff. So it's a pass-fail system, whereas the MIPS program is going to be a continuous variable. So small changes will push you further up the line. They're going to deal with the topped-out measures by giving you you can never earn 100% of your score on these topped-out measures. And to do the best you can possibly do, you'll have to choose measures that are not topped out. Now, and some of our specialties don't have any, as you've pointed out, for radiology. So, being involved in creating new measures might be your answer. Certainly, the QCDR process gives you the possibility of introducing new measures relatively quickly. But again, remember that if you're going to go after measures that aren't topped out, they're also more difficult measures, or if they weren't difficult, they'd be topped out. So you offset that. It's impossible with a topped out measure to get top points. but it's hard with the non-top-down measures to get top points, or they would be topped out. All right. So moving on. So this first measure is the total cost for care for all services provided for all beneficiaries. This next measure is inpatient spending. And in this case, we had 55 cases that were inpatient cases. Your average inpatient cost was 19 and change, where the average nationwide is 20. So we're actually a little less expensive in this region than the average, which is good, but still not enough to be in the incentive range. And then in this analysis, Medicare is analyzing the annual cost per beneficiary with certain chronic diseases, and we see that we're a little below average for diabetes, we're a little below average for COPD, we're a little below average for coronary artery disease, and we are a little below average for heart failure. And these are an overall 0.27 as the average, which is then averaged in with this to get your final score. There we go. And basically from then on, everything else is explanatory. So there's really, in the rest of the report, it discusses the adjustment factors and what goes into those, the administrative claims measures, discusses attribution processes. So, and this is all repetitive from report to report. So that was a quick look at your QRUR. They're all structured in similar ways, not exactly. Let me bring you to another one that shows an adverse report and some of the differences there. So this is, again, best medical practice, our de-identified tax ID number, and the news here, again, it tells you everything in that first page, did not meet, this says this practice did not meet PQRS reporting criteria and therefore lost the whole 4%. And again, it goes on to explain it with a little bit more detail. It's an automatic downward adjustment of 4%. Now, we miss all those graphics because it's they claim there's not data to calculate this, so they're not even presenting the scatter chart or the table. They do go into the details of the quality data that was reported, and here it is. So, and this looks exactly the same as the last, except it's specific to the quality measures reported by this group. Now, I think this is a great time to bring up that this is a good reason to go to an informal review and certainly to talk to your vendor about your data. This appears to be in error of Medicare's criteria. As we leaf through this, we see that this practice submitted the CAP survey, and when we dug into the reason why this was rejected, they claim that there's no cross-cutting measure and therefore it did not meet PQRS requirements. And when you, again, looking at the rules, the CAP survey is considered a cross-cutting measure. So Medicare blew it when they judged this to be deficient. So that should be a shoe-in for the informal review and should be easy to support. So again, don't just lie down and take these. Look at them carefully, make sure you understand, work with your vendor to make sure that it's accurate, go to the help desk with questions, make your submission for informal review. All right, so that's really about all to take from those two QRUR reports. I did want to show you a feedback report. It's the standard format of feedback report is an Excel spreadsheet. This details your performance on PQRS. And again, it has the standard format. There's a summary page. There's a page that goes through the individual adjustments for each of the providers, and then your GPRO. In this case, the submission was individual, so this page is populated. There was no GPRO submission, so this page is not populated. It is possible to have submitted both, in which case you might have both pages populated. But again, your final submission, your final judgment here is based on the best. In the case of multiple individual submissions, it's going to be the best. Well, you have to choose GPRO methods, and once you commit to GPRO, unless you've changed your designation, which is possible in the 2015 and 16 years, you will be judged on what you chose in the portal. So, by tax ID number, or excuse me, by NPI, it details the various providers in your group. What is their declared specialty from the PICOS system? Are they part of a critical access hospital? What are the total allowed charges that Medicare attributes to each of these providers? Are they subject to the payment adjustment? And this is based on So this one says it is because there's an insufficient number and type of measures reported. This one is not. It says there's a good selection of patients and measures, but this provider is not eligible for the payment adjustment anyway, exempt due to the provider's specialty. And then the list says exempt due to services not payable under physician fee schedule. There's no one that falls under that category. Exempt due because it doesn't, they have no services that fall under any measures. There's just no one exempt for that reason. Exempt because they're working in an independent testing facility or lab, and there's no one in this group that are exempt from those reasons. So again, outlines for each individual whether or not they're subject to the payment adjustment, whether or not they're eligible for the payment adjustment, and the specific reasons based on the measure submission, and then these specific reasons that might exclude the provider from reporting. So, and the individual adjustments, again, we get just reviews a method of reporting, kind of a quick judgment on that method. Was it a satisfactory report? And again, some details of each of those reports in these columns that follow. So I'll pause there a moment for questions. I have Melissa saying, what is the best process to investigate a scenario in which a practice successfully reported PQRS via GPRO registry, but received a low quality score for the claim outcome measures that pushed them into the 2% penalty range? Tough one. Oh yes, because the data really is not available to you to really investigate that thoroughly. You might want to look at your attributed list. You might want, if you can get it, you might want to look at the individuals who are hospitalized to try understanding why and how. Again, the hard part about those administrative claims measures, both costs and these hospitalizations attribute to you because the patients are attributed to you, but the decisions that go into higher cost or hospitalization may not have been made by you. And I think in the long run, the best way to control this is to be the place where your patients present for care. And improving your access so they can get convenient access at convenient times, and they're not inclined just to self-refer to other providers, to the emergency room, to specialists, where they are more likely to be admitted on the first analysis than you might be knowing them better. But there's very little data available to you to dig deeply into an adverse finding there. I am dealing with a specialty practice that's getting hit. They're attributed. They have only 20 patients attributed to them, so they've just hit the number that makes them judged. If you're below 20, that it doesn't happen. They won't include the data in your report. One of the patients had 14 at hospital admissions for a process that was unrelated to anything that the orthopedic practice was dealing with them. So they're basing their appeal on the grounds that they had no, it's not a condition they treat. And I think that's worth appealing. Whether or not Medicare will listen to that and alter it, it's anybody's guess, but it certainly seems to miscarry the intent of the regulations. We have Norma asking, we're a cardiology practice, and for our cost performance, we did better on CAD and heart failure, but not so good on diabetes or COPD. Is there anything our practice can do to get these areas up? A good question, since in fact there's great evidence that a cardiology practice is serving as primary care provider for people with severe heart disease tend to perform better than their primary care counterparts. On the other hand, when your patients have these other things, they're just, you don't have that control, and they probably tend toward the regional average. I'd say partnering with practices that do a great job in these areas to make sure that patients you're getting, patients are getting as great care for diabetes and COPD as you're providing for coronary artery disease and heart failure. It really is the I think as we go deeper into this value-based purchasing world, we're going to discover that healthcare for a community is a team effort. It's an effort that crosses practice lines, and aligning yourself with practices that do as good a job as you are is going to be extraordinarily important, and actually helping practices to learn from you and learn from your good techniques to also do as well. So it is that double-edged sword. We want to choose good partners, and we want to make our partners good, and that goes for the doctors you refer to and the doctors you receive referrals from. So let's, you can continue to ask questions. I'll pause again. I think what I want to do next is give you just a bit of a look into the MIPS system. Just a couple of slides for the high points. 2017 has been declared by Medicare a year of transition, an era of learning and development. So they've softened potential penalties dramatically. They've made it easier to comply in 2017, as they've often done when they've introduced new programs. The characteristics of this transition year, which is 2017, it could last as many as 2 years. That's kind of suggested in the final rule. We won't know until The next final rule comes out a year from now, whether it will in fact last into 2008. Administrator Slavitt did present a month or 6 weeks ago a set of pick your pace options, and they in fact have come live, and I'll show you those in a moment. We've been given at least a year off from the cost, which is weighted at 0 points for 2017, and in return, quality has been pushed up to 60 points. And quality, of course, looks almost exactly like what you've been experiencing in PQRS. The same measures or types of measures, the same types of specifications, the same methodology of reporting, with some minor exceptions. So what we've experienced in quality reporting is just a normal annual evolution. It's now got a new name, but it's really the same dynamics of reporting quality as it's always been, and now it's worth 60 points of your total 100 points in the of the 4 categories. Clinical practice improvement activities are still worth 15 points, but it takes fewer activities to get there. Advancing care information is worth 25 points, the same as it was predicted. It's a little easier to get there than it was projected in the proposed rule. Thresholds: as long as you earn 3 points in your composite performance score, there will be no negative adjustment, and that's important. It really means, and it's very easy to hit 3. There's really no excuse why anyone should have to suffer a negative adjustment for the 2017 reporting year. It is so easy to get to that threshold of 3, and we're prepared to help you decide exactly how and make sure that the submission you make is an appropriate one and avoids that 4% lumps, not lump sum, but 4% all-in loss. There's still an exceptional performance bonus. They're putting $500 million in a pool that go to the top 30%, to anyone at the 70th percentile and above for performance. So those are the characteristics. This is what they had proposed, and this is very different than quality. It's most similar to quality tiering that we looked at in your QRUR report, but it's different in the sense that we don't have the cliffs. That in this range, from at least from the about 15% to 100%, every small improvement in your composite performance score, which is this 0 to 100, that's the composite performance, the composite performance score. Every incremental change makes a difference in your adjustment level. So even with topped-out measures, where a topped-out measure couldn't get you to the incentive range in quality tiering, a topped-out measure can get you there, because at a composite score of 60, you're starting to get into the incentive range, and every little change beyond that gets you a little bit more. Now, this was the proposal, and the proposal had been that they would collect $833 million in negative adjustments from people below the 60th percentile, and they distribute it to the winners who are above the 60th percentile, with an exceptional bonus going to those above the 70th percentile. So it would look something like that. What they've done is alter it something like this. This may not be completely accurate, but it's close. So there's a cliff down here where if you don't achieve a composite performance score of at least 3, so if you don't do anything, you'll lose the whole 4%. Now, 4%, that's twice as much as your PQRS loss, and it applies to everybody, even in solo practice. So that's a fair amount to lose. On the other hand, it's less than the composite that you stand to lose in 2016. Let's say you're a practice of fewer than 10 providers. There's 2% riding on PQRS, and there's 1% each on quality and cost in value-based modifier. That's another 2% or 4% total. And then there's still 3% riding on meaningful use. So if you don't meet the meaningful use threshold, you'd lose another 3. So there's a total 7%. If you're a practice of more than 10 or more providers, you add another 2, and you're actually at 9% potential loss. So the potential losses under MIPS go down to only 4%. So it's easier on us overall than the old programs. Meaningful use is dramatically easier. Quality reporting is essentially the same. Cost again goes away for a year, but it's really not a lot different than it was in years past under quality tiering. Again, they're taking away the condition-specific measures and cost, but adding episode measures, which will make more specialists have measurable costs. So in this case, they've amended. They expected to collect $833 million from the losers. Now, since it's only this small amount who don't participate at all, they expect to collect about $199 million from them and distribute amongst the winners, and also that same $500 million bonus pool will be there to distribute those 70th percentile and above. There's still a low volume threshold, but it's easier to hit the low volume threshold. They changed the 10,000 to 30,000 allowed charges. So anyone with $30,000 or less in Medicare allowed charges will not be subject to the MIPS adjustment. And anyone with 100 Medicare patients or less will not be adjusted. Now, in the old model, the proposed model, you had to achieve both of those. So either allowed charges above 10,000 or, to achieve the low volume threshold, you had to have both less than 10,000 in charges and less than 100 Medicare patients. Either of those would throw you over. Now, either of those will qualify you. So you could have 50,000 in charges coming from 99 Medicare patients, and you will not be subject to MIPS. Or 25,000 in Medicare charges attributable to 1,000 Medicare patients, and you'll hit the low volume threshold and not be subject to MIPS. The pick your pace, all in is either a whole year of data or just 90 days. So just 90 days of quality data is all in, full access to the potential incentive and the exceptional performance bonus. Everything else remaining is the same. Your 90-day reporting period can be a different period for each of your performance categories. Some data is there, so you're giving some data about each of the 3 surviving performance categories, each for a 90-day period, and just a little bit extra, and you can earn a positive adjustment, at least a partial positive adjustment. And then the magic is that third category, one measure. Report just one quality measure on one patient that appears, one performance activity, the 5 core ACI measures. Any of those will avoid the negative adjustment. And if you participate in advanced APM, you're also that also satisfies MIPS. And if you do nothing, that one choice, if you do absolutely nothing, you're subject to the full 4% negative adjustment. And that's basically it. Tune into our webinar. We'll hit this in detail on November 9th. So I'll leave that up as we look at the final questions. Maria asks, is the $500 million bonus annual or one time? Are you saying that the rule states that for 2017, no incentives will be given unless your score is above 60, yet exceptional performance begins at 70? Well, I'm not exactly sure of when the bonuses start. The initial suggestion had been 60, and I have not yet gotten to that spot in the 2,398 pages of the final rule. I'm expecting that it's going to be around 60, that you won't get any bonus unless you're at the 60th percentile, which is what this represents. Remember that the performance score is really graded on the curve. So it's not exactly representing the 60th percentile, but it's close. So at the 60th percentile, you start earning your portion of the dollars that were brought in the negative adjustment that's distributed amongst those who are in the positive range. And of course, only the people who did nothing and are in that lowest category with a score less than 3, they're the only ones contributing to that particular incentive pool. But there's still $500 million that's in the exceptional bonus category, and that will be based on that. And we'll just go back a moment. Oops, I will go back. There we go. Based on this curve here, be distributed amongst the winners. So the higher your composite performance score, the more of that exceptional bonus you're in line to earn. And remember that this black line is actually this. So if we come here to 80 and bring a line up to here, that gives us about a 3% positive adjustment, but that's 3% X, with X being an adjustment factor that takes this and divides it amongst these by that same proportion. So your actual performance may not be 3%, it might be 1% when you get here and multiply your 3% by the X. But then again, you come up here, and that additional couple of percent actually comes directly from the known pot of 500 million, so that should be more predictable. Norma asks, is it best to report on PQRS measures that have CMS benchmarks rather than measures that the benchmark is 0? Will the measures that do not have a benchmark now be updated next year? And if so, will we know when these get updated? Oh, good question. You should expect that every measure that's newly introduced and every measure that has had a change in the specifications will not have a benchmark in its first year. It needs a whole year to go by before Medicare has a benchmark. So now there are some occasions where even a year isn't enough time if they decide that there's too much statistical variation in the data, that it's not statistically significant, that it's unreliable. They might decide not to publish a benchmark even in a subsequent year. But in most cases, every measure after 1 year of use should have a benchmark. And if they change something simple in the specs, even go so far as to say, well, for mammogram dropped off of the last year's benchmarks because they changed the time frame. They gave us a little extra time to hit the, they gave us 27 months to hit a 24-month expectation for delivery of an every 2-year mammogram. And that changed performance, and that changed the benchmarks. In the diabetes, we looked at hemoglobin A1Cs a bit ago. I believe that dropped off because they changed the time frame. In years past, we were asked to look a year prior to the first visit of the year for hemoglobin A1Cs, and in the most recent specifications, we limited our look for hemoglobin A1Cs to the calendar year. And that was enough a change in the specs to say the old benchmark is no longer valid. So just the important thing to remember is that any change in the specs makes the old benchmark invalid. Now, the benchmarks for a particular year are published late in the year. So any minute now, we expect to see the benchmarks published that will affect our 2016 reporting. So it's not until close to the end of the year, close to the time that we're putting your submission together, that we have access to those benchmarks. But we do expect to have access to the benchmarks. We expect to be able to look at those numbers with you before we submit, so that you know what to expect from that. And that's a good reason why I say, now that performance matters in quality tiering and in MIPS, you should have some extra measures in your back pocket, so that when we look at obviously at this time of the year, you can't really go back and change your approach to any measure. You're already pretty much locked into your data for the year. And so when those benchmarks are published and we look at your comparison to the benchmarks, we have a few measures to choose from to get you the best possible submission. Where do we find the CMS benchmarks? Asked Terry. Oh, good question. I can't give you the link off the top of my head. I believe we've been publishing that for our clients in our websites. So when you log in and go to our client-facing documents, you should be able to find it there. We certainly use it as we put every report together and look at them prior to submission. They're available. They are published on in CMS's PQRS web pages, so you can find it on a search there, although that's sometimes very hard to find what you're looking for there. So best place is to log into our site and grab it off of our document library. And certainly, if you talk to your, if you're engaged with us, if you talk to your account manager, we should be able to get you access to that. And we're past the hour. Excuse me. We got so tied up with questions, I didn't even release you at the top of the hour. But you're all adults. If you've got work to do, go get it done. I'll hang around for a few more minutes if there's other questions. But thank you very much for your kind attention and your good questions. I hope this has been of help to you. Don't hesitate to make requests for content that you might find useful and interesting, and we are going into a rewrite of all of the MIPS content. We had written and presented 6 webinars on the proposed rule, and we will rewrite them now that the final rule is out, to tell you exactly how those turned out. Our first presentation of that content is November the 9th. So look forward to seeing you there. So again, I'll hang on in case there's other questions for a few more minutes. All right, well, I think that must be it. So I've bored you all to tears once again. Thank you very much again, and we'll see you next time. Ta-ta for now.